بس الواحد يا دوب عارف حاجات كتير عشان انام. ناخد بس كلمتين كده بصوت خالص.
Keratoconus ده refractive. If I ask them the refractive questions, you will answer something else, by the way. I know you wanted to. Let's start by first case. Very early keratoconus, as you can see, some posterior elevation, minimal changes to the surface, with good pachymetry actually. This patient is seeking visual rehabilitation. What will you do for this patient? You have a lot of options. Let's start by Hosni.
So what's the best corrective visual active in this patient?
It's correcting to 0.8.
0.8 and
with one diopter of minus sphere and 1.5 astigmatism.
Okay, and he sees 80% or 0.8. So I will not advise him to do any sort of corrective surgery at all. But this is a stage that I would like to keep him in. So in this, and he's 24 years old. So I'm very, very trigger happy when I see these patients with cross-linking. I do not follow them up. I do not wait for any sign of progression. I cross-link them, and when they ask me when, I tell them yesterday.
For Hosni, you will not do any refractive surgery. You will cross-link the patient first.
The reason for me not doing any refractive surgery is that his vision with his glasses is good. If the vision with glasses is compromised, then I will take a look at the hyperboreal aberration profile for this patient. If I see significant coma, then I will do a selective hyperboreal aberration for them. And in these patients, I cross-link them first, wait for a good 3 months, and then, because sometimes the cross-linking changes a little bit the profile of the hyperboreal ablations, and then I do selective coma ablation, and
so usually you will do treatment.
He sees 0.8, I will not do anything. If he sees less than 0.8, if it's like 0.6, then I will definitely.
Okay, but 0.8 you will not treat.
Yeah, just cross.
Dr. Shafi.
Yeah, he's an old guy. I mean, he's like 29 or something like this, 24. No, if you subtract this from this, it's 28. Yeah, 28 years. And my experience, if you do your cross-linking for those patients, they become very happy. I mean, many of them have got rid of their glasses just like because the myopia that you're
But will you promise him that after
No,
cross-linking,
I can't.
he was asking specifically for visual rehabilitation, this is his question. You might get lucky after cross-linking and the patient is lucky, but you can't promise the patient.
No, yes, of course, no promises. In cross-linking, no promises. But you will tell him that you have a high probability that you will get rid of your glasses even, and you become happy because the quality of vision will improve. And after that, you know my protocol. If he's insisting after cross-linking, I should build at least 6 months and do for him a different guided PRP. Starting from March, when I have the ray tracing machine, I would love to change I mean, we've seen the data provided by Consumo Mazzotta a few hours ago, and actually I would treat him his ectasia and do a cross-linking the same time. Yeah.
The ray tracing magician.
كوزيمو مازوكا شكله مشهور برضه تقريبا، شكله مشهور، أنا تقريبا سمعت اسمه قبل كده. كوزيمو اللي هو التالت ده؟ تالت صح؟
The same.
أنا حاسة إن أنا سمعت اسمه.
Bilateral keratoconus.
Yes,
No
tricks, don't
visual
worry.
acuity, the best spectral corrected visual acuity is
20/30,
okay.
0.8.
He is tolerant or not to contact lenses.
He can't tolerate contact lenses.
Tolerate?
No, he can't.
No, he can't.
No soft, no hard.
Okay, and this patient want to improve his visual acuity
Yes, without glasses.
without lenses.
Because his glasses is already giving him a
In this
slight.
case, I agree that you can do a ray tracing based treatment cross-linking simultaneously.
This, you can see that this is an indication or it fits the criteria of ray
Because
tracing.
fits the
Good
criteria
thing,
because
yes.
the age is around 30. The minimum corner thickness is very good because we are over 500 microns.
Yes.
The keratoconus is a peripheral keratoconus with a prevalent chromatic contribution. So I think it is an ideal candidate if you want. So of course you should start from the worst side, and the other one maybe also not.
So simultaneous ray traced customized surface ablation with accelerated cross-linking at the same setting.
I don't think it's a peripheral keratoconus, that's an axial map. And if you look at the correlation with the steep spot with the posterior and anterior elevation maps, I think it's more central. But I wanted to ask Cosmo, do you ever do customized cross-linking where you target just the one? Would you do that here instead of your?
I tried, and I had no predictable results with customized procedure. I had different kind of flattening that were not predictable like the next so yes, I agree with that.
تقريبا محمد شفيق او حاجه رأيك يعني تقريبا ليه رأي او حاجه.
Sorry for this.
I think for me, I'm going to tell the patient, he's coming for refractive solution.
Yeah.
And then we ordered for him the pentacam. And we found the problem.
No, he already did all this long time ago, and now he's seeking any sort of visual reality. He knows he has
He knows that he has
keratoconus.
keratoconus.
Yeah, but he's looking for a new advancement in this field that can help him to get rid of his glasses.
Cross-link, wait for 1 year, and then reassess.
Yes.
1 year.
If it
Not
is stable,
3
by
months,
the way, this
not 3
was.
months like Husni said, or 6 months like Shafiq, no, 1 year. Wait for 1 year after crossing and then reassess. Is everything okay? You can do
Do you have any advancement in Saloniki?
First of all, this is not an axle, this is not a digestive map. So that's one. Problem number two is that if you had asked me 5 years ago, I would say any kind of customized PRK with cross-linking, but that was 5 years ago. Because for me, ray tracing, ray from the top of my head, all have a place, especially this. But now, I will just follow. I will do nothing. There's no, for me, this is a very early case. He can see very well. The age is not terribly dangerous for progression. So, because I've heard that the term prophylactic cross-linking, why? Is there any other cross-linking? All of it is prophylactic. If I have to do cross-linking, I will probably do customized cross-linking and not touching him. But having seen the after cross-linking results, I don't want him to come in my clinic in 6 years' time with hyperopias. So, you know, as you grow, you do less.
Okay, we'll start from.
I wanted to make a comment about Cosimo's ray tracing. That's not done with curvature, it's done with elevation. So he doesn't care whether it's axial or tangential if he's applying his ray tracing approach. Because you just have the elevation of not even the elevation, it's not relative to a sphere, you just have the surface of each one relative to each other and then ray tracing for the same.
Okay, another case of more advanced keratoconus. This patient is correcting to 0.3 with -2 and -3 astigmatism. And he's seeing double vision and some shadowing. And what will you do for this patient if you're going to treat him as keratoconus?
In this case, we have a patient with a problem. We have a patient that we have to improve visual acuity somehow. I think it's by the difference in the map. Of course, I had to see it again with digestion and also the wavefront of this patient. I would probably go for a wavefront guided cross-linking. Because the age is very young, so yes, you want to stop progression with the cross-linking, so you are legally right to do that. And B, improve the visual acuity if we can, but not paying too much attention on the refractive status rather than improving the spectacle correct visual acuity. I would think, as an option, now that I have all my friends that are telling me, put rings, of course I would think ring as an option. Guys, no, not now, but maybe in a couple of years' time. But I think still I would rather do a good old-fashioned wavefront guided Purkinje cross-linking in this case, because this is a case that it will improve by that treatment.
Dr. Ahmad?
Intracorneal link segments with cross-linking at the same time.
Clear cut. Cosimo?
Oh, yes. Which is the visual acuity of this?
0.3.
0.3.
Yeah.
And the other eye?
It's similar.
Okay. Ray tracing guided cross-linking. Ratio and cross-linking.
So, you mentioned ray tracing.
It's very good for the corneal thickness.
Mentos, you mentioned wavefront guided cross-linking.
It's the same.
Similar.
Wavefront guide.
Wavefront guided.
Wavefront
Yeah.
guide.
wait,
Ray
wait, wait,
tracing.
wait, wait.
Ray tracing.
Wait. Ray tracing and wavefront guided are not the same
No,
thing.
no, it's the same because there are two different approaches that can be used.
Oh, okay, but they're
No,
they're different.
totally different.
Because
But I quote Milton's decision, this is a case that we need to improve best spectral correct.
You wouldn't think of cares or something like this in this case? Cosimo, you wouldn't think of cares?
No, this is not good for cares. No. The cares are for more and more advanced.
More advanced.
Dr. Shafiq?
I agree totally. After touching and seeing the results of the ray tracing, I really have a good for I was until last year, I would cross-link the same patient and then wait for 6 months and do a wavefront. But now, the ray tracing and simultaneous one, I will do it.
Dr. Hosni?
This is a case that I would definitely treat. The problem is that it has a bad, best corrected visual acuity. So this is a case I will definitely cross-link and then wait for 3 months and then do a selective high order ablation treatment. But again, this is not for glasses or spectacle independence. I will tell the patient I'm not doing this.
Yeah, we are sure.
Yeah, so the 0.3, I will push it to a 0.8 like the last one, and I'll be very, very happy. And I have just a quick question for Miltos, please. Can I?
Yeah, sure.
The cases of progressive, and this is a question that I really would like to. The cases of progressive flattening over the years, we all have these cases. Were there in mind keratoconus like this, Miltos, or most of them had high Ks?
We didn't find any, let's say, relation with the stage. We found a relation with the cornea clarity, with densitometry, but still, it's not published, but definitely there is a relation. And no relation yet with age. So densitometry, PRK, these are factors that certainly play an important role in the flattening, not the stage. At least to
So you can end up with progressive flattening over the years, even in mild cases, if you've done like a reasonable cross-linking, like that's accelerated progression.
That's the thing. I mean, this case reminds me a friend of mine, an ENT surgeon, that came and I said, okay, yeah, well, that time we'll do a very nice photography guide with cross-linking, and now he's fast forward.
So it was an
It was a kind of a stage 1, stage
So
2.
it was an Athens protocol. It was a PRK with a cross-link.
PRK cross-linking.
And the cross-link was Dresden's protocol, the long one. Yeah.
I totally agree with the discussion that I had with Vincia before. The shape of the ablation will govern the degree flattening later on. And we are all suffering from those patients which we applied at Athens protocol, and we simultaneously cross-linking them. But now she has a point of view. I want you to declare this point of view.
So, any time you sever lamellae, it will generate central flattening. If you remember which patients get a bigger response, so this patient may not be older, but when you cross-link them, it makes them stiffer. So you will get a bigger flattening effect. And because the cornea is viscoelastic, that means that viscoelastic is something that it takes time to change. So it's adapting to its new environment. And so it's going to drift until it stabilizes.
But again, I will agree, we didn't see after 2 or 3 years flattening in your rear case, we see only now cross-linking. So cross-linking is playing, for me, cross-linking is the major component of this flattening, the major player. Unfortunately,
It's stiffer. It's the
Or
same
maybe
response as
the
the older.
response.
So you make them stiffer, and if you make them stiffer, you potentiate the biomechanical flattening.
Okay. Now we have 4 laser with cross-linking and 1 intracorneal rinse with cross-linking. Cross-linking, everybody agrees on that? But since Dr. Ahmed Masri asked me, and this is my patient actually, so, and I don't usually give my opinion, but I put an asymmetrical intracorneal rinse for this patient, and the patient is doing extremely fine after asymmetrical for dark shade phenotype. The asymmetrical, 200, 300. 200, 300 Kera
Without cross-linking.
anti-global. Of course, with cross-link.
So which one? The sinusoidal one with the middle part?
Asymmetrical.
The variable thickness, they are either sinusoidal or
The sinusoidal is 230. No, it's not sinusoidal. It's starting from 200 as the periphery, and then you have to increase it to 300 as the inferior part.
okay, because the other one starts 200 and 300.
Then 200, yeah. But this is for inferior keratoconus.
Yes.
This is the duct type.
Oh, it's in slow
Just one comment from Coach
Okay.
because he wants to add something.
Go ahead.
In our retracing ablation, we choose very small optical zones, also 1.5, 2 millimeters optical zone, and we work on the connection zones, maximize smoothness, minimizing ablation, and doing very large optical treatment with a constant slope, with a constant gradient slope. So we don't have the effect of the larger optical zone that we are doing. It's completely different.
Case number 3. It's a very interesting case of post-LASIK ectasia. This patient is suffering from post-LASIK ectasia because of high myopic correction. She's 50 years old, she's a doctor. And the thing is, the ectatic is nipped in the center, and the patient is correcting with minus 17 to 0.5. Really? Yeah, and if you can see the spherical aberrations here, it's huge. This is why she has a huge myopia. It's spherical aberration is -2 actually. And here is the tangential map. The tangential map. So you can see the true localization of the ectatic area. And now we have the ectasia center on the center, focal or small area of biomechanical problem. And the patient corrected visual acuity is not that bad. She's with minus 17. Okay, forget about the minus 17 right now because it's the thickness is 280. 280. The cornea is crystal clear. No, what will you do for this patient?
For me, I would cross-link her with a
This is the question.
or an
How will you cross-link this patient?
Yes, an M protocol or a sub 400 protocol, and after that, she will be treated as a diet myopia case. If she's young, I will put for
She's
her
50 years of age.
50 years, fake.
Take of course.
Yeah. But after
But you will cross-link her.
yes, first of all, she will be converted into a eye myopic patient. And straightforward.
The M,
With the M protocol.
not the suffering.
What?
Don't say again.
Suffering.
Okay.
Which protocol will you choose? So,
Yeah.
so
Which one?
do we agree that we will cross-link this patient?
Let us leave the declaration or the comparison between M protocol and sub 400 for procedure.
So, Cosimo, will you cross-link her first?
The visual acuity with the myopic correction is good.
6, 12, 24,
Okay.
0.5,
So
whatever.
you need to stop this ectasia. And you can treat also with this very thin cornea. In this case, you have two protocols, the sub 400 and the M protocol. The M protocol allows you to keep constant 5.4 joule fluence. So the same of the Dresden protocol for corneas over 400. But you need here to choose 30 milliwatt.
30 million.
30 milliwatt. You can treat in any off. So if you remove the epithelium here, you have
Going to be
230
240.
microns
No,
of
the epithelium must be stand out. It's a very huge cone. So maybe
Okay.
it's 40 microns, for example.
30 milliwatt pulsed, 6 minutes. So you can do a corner soaking with riboflavin 0.25% if possible in the new nomogram, or if you have 0.1, okay. 10 minutes of soaking, remove the epithelium, and then use 30 milliwatt pulse at 5.4 joule. And you will have a cross-linking around 150 microns of demarcation.
One quick comment.
Did you say this is post-lace?
Yeah.
Okay, so can you go back to the tangential map?
But I would like to comment, is it a true pachymetry? I mean, in such conditions, beta cats fail to bring the true pachymetry.
It's proven by
You know
prosecution.
what? We need to know how much of that is interpolated because Tenicam has a feature that you can turn on where it puts black dots where it's interpolated. You need to know how much of that
There
data.
is no black dots. I think this is 9 millimeters zone.
Yeah, but if it's a 9 millimeter zone, there's going to be black dots. It's turned off. That you can turn off the black dots.
No, it's here. You can
You
the
see black
dots in the
dots?
periphery. Yeah. I didn't even.
Guys, here we have.
Anyway, this is coming, can you go back to the tangentials? You're smoothing things. This is coming through a flap. That's coming through a flap. It's highly irregular. It's not smoothed out like the axial. Now, Cosimo told us yesterday about putting this ablation in the flap. Now, that's not going to change the bed at all. So you could do the ray tracing in the flap and have no impact on sacrificing. You would do it here? Why not?
Okay, we have to move faster because we are running out of time. So
With the 30
cross-linking.
diopters of myopia so central, absolutely the in the flap ablation is not
Dr.
indicated.
Masri, will you cross-link this patient?
No, this is an airplane crash with 100 people died, and now we're looking for where is the black box. Come on. This needs to be treated with an additive procedure. And again, if I have to choose, really, do I have to maintain this poor man's vision as it is now? Cross-linking, the best we can do with cross-linking, if you're not damaging the endothelium, which we will, in any FMLOP protocols that we use, we will damage. It's going to have a miserable visual acuity, and you maintain a miserable visual acuity. This has to be an added procedure. Epikeratofakia, if you don't have a tissue, then you can use a part from a tissue or a good that will give him a good result at the end. My opinion is,
she's refusing any sort
if
of
she refuses, it's okay, it's up to her, then treat it with scleral contact lenses. But stopping this with maintaining this kind of visual acuity, I'm not offering any option.
Run that again. Run that again.
Okay.
I want everybody to see how much it's flopping. Watch that. Run it while you're talking. Watch, look at this. Look at it bounce. That is a very low stiffness. And I think you're right. I think you're right. I wouldn't take anything of this.
Okay, last question, because we have to leave. This is the other eye of the same patient. No, we have to leave the stage.
We have to leave.
I'm saying, this is the other eye of the same patient, and she mentioned that when she did LASIK 9 years ago, she had minimal myopia in this eye. So this is the condition right now. Do you think you should do something for this eye or just wait? She's starting anesthesia. You will treat cross-linking, 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 Dr. Ahmad. Wait.
If there's a big difference between both eyes, wait.
Send to Siena. Send to Italy.
Okay, if we change the scale a little bit, you can see that there is some sort of posterior elevation here. Yeah, but if you look at the Corvus data, for this eye, you can see that the CBI LVC is compromised. So will you change your idea if you see the Corvus showing that the data is compromised, you will be in a hurry to cross vision? Okay. As usual, okay. Just one slide. What I did is this patient actually I cross-linked her. It's a very thin cornea, I cross-linked her, and after 1 month there was some stiffness noticed on the biomechanical evaluation, but we still have to see what's going on. Okay, thank you to the panel, and thank you everyone for attending our panel.